Much, Fernando, for your excellent presentation. Now, I think the title of this session is because he will talk about the role of psychosocial factors in women with acute myocardial infarction.
Thank you. Actually, I was thinking that after two super specific titles, I have this title of acute coronary syndrome and say, wow, I mean, Antonia actually trusts me so much that she lets me to speak about anything I want to say. And actually, that's what I've done, because I didn't know that I actually had one other title. So these are my conflicts of interest. Actually, none of them apply to this particular talk. So you probably have heard this, the Gentle syndrome. If you remember this is a book by Isaac Bashevis Singer. He was a Jewish writer. He was a Nobel Prize. And probably you know, maybe not the book, but the film by Barbara Streisand. And it was a lady who wanted to study the Talmud, which was restricted to only for men, and she pretended to be a man so she could actually study the Talmud. And this editorial, this is 1991, in which after two papers showing how big differences are in the management of acute of coronary artery disease between men and women, they were saying, would the women need to pretend they're men, so they're treated as well as men, or they receive as many diagnostic and treatment procedures as men for that? Well, I think after nearly 30 years after this, well, this is probably still the situation, if we heard a little bit of that. So why is that? I mean, is it still that we hate women and we really want to mistreat them on purpose? Is there reasons for that? I'm not going to get into the biological things, the sex reasons. There's obvious sex reasons. I mean, women are different. There's the estrogen issue, of course, and the time dependence. Coronary artery disease, there's a 6 to 10 year gap in the development of the disease. They're smaller, the coronary arteries are smaller, the proportion of fat increases, particularly after menopause. That actually makes a difference in terms of drug dosing, overdosing, which is very frequent, bleeding risk. The time gap, the age gap actually makes a difference. You cannot compare a 65-year-old woman with a 55-year-old man, which is usually done because there's this gap. So actually there's many reasons, but the issue is that we're giving exactly the same treatments for men and women, despite this difference. There's also this renal function difference, these weight-adjusted differences. So actually these are some of the reasons. Interventional cardiologists, in particular surgeons, know the difference of treating women, how these coronary arteries are smaller, are more fragile. So actually the rate of complications for interventions are higher in women. And there's some physical reasons for that. So it's not only about let's say, gender issues. There's some biological differences that should be taken into account. But that's not reason for not giving them what they should. It's only a need to see what is the optimal treatment for them. And for instance, we just have doses for men and women at the same time, despite these differences. And we need to rethink that. And actually, that's one of the reasons why this overdosing with anti-thrombotic drugs causes so much bleeding in women than in men. But I'm not going to get into that. So fortunately, actually, most of my talk was going to is going to fit what I was expected to see this, but I didn't know it. So, but I'm going to speak about a few things that make the difference. So one is this myth. I think it's been myth that clinical presentation of acute coronary syndromes is different in women and men. And this been, I mean, we've been hearing this for decades. And there's hundreds of papers saying that this is the case. But is this really the case? Oh, I have a problem. The animation is not working. So below, there's a graph showing, this is a prospective study. So let me tell you, most of these hundreds of papers saying that actually the chest pain and the clinical presentation of women is different than men are retrospective studies. The now recent prospective studies showing, and there was a graph, please look at the paper and you will see how actually all the features of chest pain or clinical presentation actually fit better in women than in men for typical presentation. And actually these authors, these come from Scotland, say that more frequently women present with chest pain, and actually typical presentation is more predictive in women than in men for acute coronary syndromes, and this should be acknowledged. So this is dispelling this myth. Actually, we studied this in Virgo, and when we prospectively analyzed these thousands of patients with young patients with men and women, you can see that there's basically no difference in the presentation. So chest pain was nearly 90% for men, and for women with real no differences. The response from patients to these symptoms were similar in men and women in the US and in Spain. And interesting enough, actually more women than men actually sought medical care for the symptoms. So still there's many myths in these times of clinical presentation. What it was different, and this is what is striking, is the provider, the healthcare provider, did not think that symptoms were heart-related. That actually happened for half of the women, as compared with 1/3 in men. So the problem is probably not in women, it's probably on us. So my question is clinical presentation different, or this is a prejudice or the excuse of the indolence of us? That is, when we discharge a patient after chest pain, or we don't do an ECG, or we have delay in acute coronary syndrome, they say, well, she had atypical chest pain, and I couldn't find it. So I'm wondering whether this is a myth that is just our excuse of our indolence, of our ignorance, and this would be an example of sexism. And I think this has to come to medical schools, because I think we're even creating this myth, which is actually a sexist myth, and we need to change that. Second point is this difference, and you just mentioned, Minoca is more frequent in men than in women. That's actually true. For instance, for STEMI is less important than for non-STEMI, and for chest pain is more frequent. So it is true that women more frequently present without significant obstructive coronary artery disease than men. And so one of the reasons is why do women undergo less often coronary angiography or interventions, part of this is biological, because they have less coronary artery disease. Whether this means that they should receive less dual antiplatelet therapy, we don't know really. But actually, and then I'm turning to the other side, whether there's a biological reason to make difference, yes. Whether this is appropriate or not, we need to adjust for these differences. So we have to be careful, because sometimes we just say it's white and black. That's not the case. There's things that may be black and white, and actually if we compare the black columns, probably we will see differences between men and women. But there's other differences that should be taken into account. But we need more research on that, because we're still extrapolating from one to another. Well, we have these differences. And that's a problem. And that's a problem of these, I would say a male-oriented analysis of the disease. And we need to take account for that. But I'm going to really focus on this psychosocial environment. And I don't know whether actually Andrea or Susana, Felicita, Victoria will apply to your countries, but I'm going to show you as an examples in Spain, which I think they're very relevant. First thing is actually the education level in women still in Spain are lower in men. I think this has changed really a lot, but still there's a disproportionate in the rate of women with lower levels of education. And remember that socioeconomic levels is one of the most important determinants of cardiovascular disease. So from the beginning, even nearly from the start, women have an unfavorable environment for cardiovascular disease. Second thing, Even for the same level of education, unemployment rates are higher in women for any age level, for any educational level. And an employment rate, of course, it is related to wealth, to stress, and to many things. So regular women, before even thinking in cardiovascular disease, have a worse environment. Not only that, when they work for the same level of education, women have lower salaries. And that's a continuous situation that I still have. That's one other situation. But the fact is that actually, even with the higher unemployment rate, actually the level of work of women is higher. And look at that curve. It is the pink curve, what is the productive or the salary, the paid work, which is higher for men and for women about any time, but actually the unpaid, let's say the domestic work, which is in the blue line, is always higher from the beginning to the end in women and men. So at the end, actually, women work more than men. The thing is that actually their work is not considered employed, is not paid. So what we have now is women trying to cope with the situation, and I think this is a social problem. We live in a crazy world in which our work is taking more and more of us. So women have to cope with this work exactly as men, with the difference that I mentioned, with, more difficult reach to work, lower salaries, more difficulties in getting it sustained, but also they have to cope with all the work at home. And this is really a situation that makes women different in terms of social, economical situation. But it's not only that. And this is maybe more cultural. Definitely it happens in Spain, probably in Italy it's the same. Actually, culturally, women take care of the disabled, of the sick people, whether they're children, whether they're their grandfathers, actually their fathers or mothers, or actually their husbands, father or mother. Actually, there are many more women taking care of those who need care at home, at any age, at any time. And this is, again, unemployed, or is not considered unemployed, it definitely is not funded. And we know that actually taking care is associated, and see this, this is for Alzheimer's specifically, which is probably very burdensome, but actually 60% of caregivers think that their health has been damaged for this need. Actually, 40% of these people, of caregivers, usually women, and it's funny because even the pictures actually are drawing men, well, actually they're mostly women, think that actually the health of the person they're taking care of is more important than their own health. That's very important. And actually, 60% of these caregivers think that they need medical attention. It's not that they're a little bit stressed. They need medical attention by depression, anxiety, and stress. So we shouldn't be surprised, and we find out that actually this is the situation between a working man and a working woman. That is reality. So I think, and does this impact on health? How can it be? Even before disease, not after disease, and we will talk about this later. So we wouldn't be surprised that actually the levels of stress for women as compared with men are much higher. So nearly half of Spanish women refer that they're really, really stressed, very high levels of stress as compared with men. The levels of anxiety for any age are much higher in women than in men. And the proportion of women with depression is double than the Spanish men. In fact, that actually happens for any age, and for the severity of depression in the red colors is always higher in women than in men. This is no surprise. How cannot this influence our pre-patients, that is the risk of cardiovascular? Nobody has really done a prospective study of what is the influence of this home work, conciliation on cardiovascular risk and cardiovascular care and cardiovascular recuperation. So I think how these psychosocial factors influence this. We need more research in that. We did some, and I think this is one of the influence. This is actually the first picture of black hole. This is a real picture. But I think one of the black holes that we have is the use of cardiac rehabilitation by women. And we've heard that. But I think one of the reasons is all these things. I mean, women after myocardial infarction, they have to go home and have to take care of cooking, shopping, cleaning, caring of the old person or the children. And so they just can't attend cardiac rehabilitation. We just do a standard thing. We offer a thing in the morning, which says you come or you go, and then women do not come. And they don't have the offer. So we have a problem in the system, because we're not offering what women need. So we actually need to change not only the society, we need to change the system to offer what women need, because they have different needs. And this is creating less opportunity for women. But as I mentioned, we studied some of these factors in this Virgo and Hoven study. This is a shared study between the US, in where we have 100 hospitals and 3,500 patients. These were myocardial infarction in young patients below 55 years. We had 24 hospitals in Spain and more than 500 patients. So altogether, we had nearly 4,000 patients, which is a large number. We had these regional differences too. So this is a comparison of some psycho-functional comparisons between men and women. So men are the blue lines, and women are the red lines. And you can see actually to the right is better, to the left is worse. And you can see that actually for physical functional, mental functional, disease-related quality of life, and general quality of life, actually women were worse than women. That was after myocardial infarction. But there was two issues in which actually women actually had scored higher than men, which was for depressive symptom and perceived distress. Any surprise on that? This is what we have. So what we have in real life, actually we have in after myocardial infarction. There's no surprise. So if we don't take into account the situation, the psychosocial situation of women, we won't be able to really take care of women fully. And that actually applies for nearly everything you look at. This is the functional, the recovery, functional and quality of life in men and women. This is a baseline, 1 month and 12 months. And you can see for whatever you look at, women's scores are always lower. That is, they feel worse, the functional status is worse, their quality of life is always worse. Actually, when you see perceived stress, you can see the full boxes are women, the open boxes are men, and you can see that perceived stress is higher in women than in men, in particularly driven by the score of negative items in women as compared with men. And if you go through the evolution, and you see in the left men and the right women, that's baseline 1 month and 12 months, you can see that the scores of stress for women are always higher than for men. That is before. That is not related to the disease, but actually after the disease, although everyone improves, so after the shock of having a myocardial infarction before 55 years, which is a shocking situation, but this increases the level of stress. This goes down after 1 month and 12 months, but still the levels of stress are higher in men and women. In fact, female sex, also in our study, was found as an independent predictor of depressive symptoms in young patients with myocardial infarction. Again, no surprise. But let's talk about practical things. Return to work. You can see that both in Spain and the US, actually the proportion of women returning to work is at 1 month and 12 months is lower in women in men. So it's not the physical, it's not the well-being, it's actually the source of living and the work of this the impact is higher in women than in men. These are young patients. Sexual activity is very important. Well, it's very important at every age, but actually it's more important in younger, or it's more relevant. See the proportion of patients who actually had a discussion in the hospital with their physicians, usually cardiologists, and you can see that both in the US and in Spain is really low. 19% in the US as compared with 12% for women, lower for women than for men, and it's even worse for Spain, 17 and 13%. But even worse, the proportion, the very low proportion of women or men who actually talked about sexual activity and the risk, actually you can see that 60% in Spain of men, but 83% of women actually receive wrong recommendations about restrictions on sexual activity, like taking their pulse, holding, staying passive, and stupid things with no evidence base. So basically, there's no information, and the little information is completely wrong. We have a real problem, but these are real persons, and sexual activity is one of the important activities for health as a general, and we're doing completely wrong. And actually, female gender was one of the independent predictors of not receiving sexual advice, and actually being a Spanish woman was an independent predictor as compared with being an American woman of receiving wrong prescriptions in terms of returning to sexual activity. So we have a problem. I think we have a system problem. We have a universal problem, but still we have a higher problem in Spain. So that's something that we have to take care of. We don't care, as cardiologists, because we don't see persons. We don't see patients as a whole. We just think about the coronary artery. We see the heart, the cardiovascular system, and we're wider, but we don't see all these things. And if we don't really consider these issues, we're not doing acute work. This is sexual activity after 1 month and 1 year, and you can see that actually women do always worse in all features. Partnership, sexual activity is lower, baseline. At 1 month, see the impact. Nearly half of them stopped, didn't return to sexual activity after 1 month of myocardial infarction. But even after 1 year, still there was a proportion that didn't return to have a sexual activity. And this proportion was always higher in women than in men. Same with communication. See communication after 1 year, how low the proportion of patients after 1 year. That is not cardiologists, we don't care, but it's the general physician, the primary care physician. Nobody explained them. So it wouldn't be a surprise again that actually the proportion of patients with sexual problems after myocardial infarction is high, always higher in women than in men, even after 12 months. So we have a big issue here. There's no industry. There's Viagra and so on. For men, probably there's a little bit different, as there was not an industrial interest in that. This is a, let's say, orphan situation as many others. And I'm going to finish with one, I would say, scary question. Is with actually, does the sex of the health provider, the sex of the physician, makes a difference in terms of quality of care for women? Because you know that usually, you see, always the problem is for women. So this is a theoretical study. So these people, what did is evaluated a number of beliefs in a number of physicians, cardiologists, actually, in terms of perception of gender issues. So it could be to the extreme of being very important that there was big differences between males and females, and there's the difference on the other side, females to males, or neutral. And actually what is important is that actually these beliefs make a difference. This was a theoretical cases in which patients with symptoms suggestive of coronary artery disease, and then I'm coming back to the beginning, would make a difference in terms of ordering and a coronary angiography. And you see that actually the belief of the physicians would make the difference, would make a difference in terms of ordering a coronary angiography in men and women with exactly the same symptoms. So it is true that our beliefs, and this is gender, and this is actually scary, actually makes a difference in the way we prescribe, for instance, diagnostic techniques. But even worse, in the case when a patient was with abnormal stress test with the same level of risk, this difference was even greater. So the beliefs, our beliefs in terms of gender as a physicians make a difference in decision making. This is a theoretical construct, but what is scary, does this translate in different results for men and women? Well, actually we have some preliminary results. So this is a number of a study in surgeons between women surgeons and female surgeons and male surgeons, and you can see that the results in this cardiothoracic surgery is borderline significant for a better care for female cardiovascular surgeon as compared with male. I mean, this is just a preliminary. I don't think this is strong evidence, but we need to take care of this because, I mean, probably there's something behind that. In fact, in this one other study analyzed the probability of survival. I'm talking now about real survival between the matching between male or female patient and male or female doctor. Actually, the worst combination was being a female and having a male doctor. And in fact, this is the proportion that they say. This is the having a female doctor and a female patient would be the ideal situation, and having a female, I don't know, I don't think this is strong, but I think we need more research in that because this is scary. And would you be surprised that these gender issues that we have every day in our society do not apply to physicians, do not apply to the system? I think probably have. So we need more science in that, because this is important. Because at the end, who are more frail for that are women. So my conclusions is that we still have many open questions regarding the influence of sex and gender on the diagnosis, treatment, and prognosis of acute coronary syndrome. So I think things are not black and white. There are biological situations, but there are sociocultural situations that we need to take into account and to understand how these influence our management and the prognosis. But there's one clear thing: psychosocial factors play a real important role in several aspects of cardiovascular disease in women, also in men, but actually they're stronger in women. So we really need to change our close view of cardiology, of cardiovascular disease. If we stay in the heart, on the coronaries, in the heart, on the cardiovascular system, we're falling short. We really need to open it, and we really need to start let's say, having a multidisciplinary and open view, taking into account all these factors that usually physicians in general do not really care much, but actually they have a very important role, and we have more and more evidence that this is the case, and this is the case particularly for women. If we don't open our minds, if we don't change the system, there will be no solution for that. Thank you very much for your attention.